you.
And it's starting right now, you're recording. So I'm gonna
Yeah.
quickly repeat what I just said, just so you don't have to write down everything while I'm talking. It'll go a lot faster that way. Okay, so again, acute myocardial infarction, coagulation necrosis. Here there is section margin. This is normal cardiac muscle. And when you go deeper inside, you can see it becoming necrotic. Okay, tissue architecture is still there. You can see it, but the cells are losing their nuclear material. And this is probably what you're gonna get. And this shows extravasation of blood. And the tissue is a lot more eosinophilic. Okay, and with barely any nuclear staining. All right, and if you see areas like this is partially digested blood. Okay, sort of like hemosiderin.
Okay.
All right, got it?
Yeah.
Okay, next up. So this is gangrene in the lower leg, and gangrene is another type of coagulation necrosis. But here the tissue architecture is completely obliterated. So I'm gonna zoom in a little bit, so you'll be able to see that this is striated muscle. Okay, so we can see like these cell bodies, and you can see the nuclei in the periphery. Okay, so this is striated muscle, but you see this is inflammatory infiltrate already. Okay, and it's starting to lose the striations. And the area that's very necrotic is here, and that might be what they actually show you in the exam. Or going further here, you can see there's a lot of immune infiltrate. You can see that the cells completely lost their nuclei. It's very it's not very nice looking like the normal muscle tissue. Okay,
so you mean like infiltrate by like the neutrophil? I mean
yeah, this is neutrophilic infiltrate. Okay, okay, and you can see like remnants of muscle here. So the eosinophilic stuff, that's what remains of the normal muscle.
Okay, so the purple, like this dots, is like the neutrophil, right?
Yeah,
And
exactly.
I mean, like this left portion of this picture is like necrotic region.
Yeah, so it's all necrotic, even where the immune cells are. It's all necrotic. But this is remnants of the muscle cells, of striated muscle cells. And these are just the neutrophils that are infiltrating here.
Okay. How about like right portion, I mean right side of this picture is?
Like here? So this is a more normal looking muscle.
Normal. Okay, the striated muscle, this is like normal.
Yeah, pretty much. I think there's some inflammatory infiltrate in here too, just because it's being influenced by the necrotic part. But yeah, this is more normal. You can see the cell bodies, some striations, and nuclei in the periphery.
Okay.
Okay?
Okay.
All right. So next up. So this is fat necrosis in the pancreas. And if you can like imagine the pancreas, it's yellowish, it's completely wrapped up in fat. And this would all be fat, okay? And these darker areas are normal pancreatic tissue.
Okay.
I'm gonna zoom on them. I don't know if they're gonna show it to you or not, but you should know this. So this is an islet, a Langerhans islet. And all of these are pancreatic acini. Okay, this is just full of so this is the exocrine portion, and this is the endocrine portion. And this is normal. But and I'm gonna show you this area. So this is a normal fatty area. These are all adipocytes. So this is normal, this is not necrotic. And what they're probably gonna show you is this area.
Okay.
And you can see that these are adipocytes, but you see that the membranes are kind of ruined. They're a little necrotic, and you can barely see the cell nuclei. So you can see maybe one here and maybe one here, but like this cell doesn't have a nucleus. So this is necrotic, and what happens here is there was an acute inflammation, so acute pancreatitis, and that led to pancreatic enzymes being released and activated in the tissue. And they reacted with the fat inside these adipocytes, and it created this. So these cells are full with calcium soaps, and the process is called saponification.
Yeah. So this cell is like necrotic adipocyte, and you said like this cell doesn't have the nuclei, nucleus.
No,
but like usually adipocyte, I think, doesn't have the nucleus, right?
They do. They're live cells, but their nuclei are at the periphery. I'm going to show you normal adipocytes.
Okay.
And you see these. Now, I can't tell you if this belongs to this cell or if it belongs to the cell next to it, but they do have nuclei. They have an active metabolism. And the nuclei are just at the periphery. Okay.
Okay, and could you show me again, like the necrotic region?
Yeah.
It looks like.
Here you go.
Yeah, and we
so
cannot
see the membranes are broken down. You can't see any cell nuclei, and you can see this material here.
And even like inside the cell, we can see like the pale, like the
it's more basophilic. So this is all calcium soaps.
Okay, so this is like one more marker for the necrotic region.
Yeah.
Okay.
That's all you need to know about this.
And like wait, this like the dark area is like the normal, the necrotic region.
No, in the bigger slide. No, these areas are normal.
Normal, okay, normal. Okay.
And that's necrotic.
Okay.
Okay.
Got it.
Right. Next up. So this is caseous necrosis in a mediastinal lymph node. And when you present the slide to your examiner, always mention the staining.
Okay.
So the first three slides are in normal H and E. And this one is in Ziehl-Neelsen. And Ziehl-Neelsen is specific for Mycobacterium tuberculosis. And it stains mycolic acids. These are these fatty acids that are found in the bacterial cell wall, in mycobacterial cell walls. So here, I think there was some hematoxylin added, okay, because I'm going to show you why. Just because you can see all of this nuclear staining. These are all immune cells. Okay, but what you're probably going to get in your exam is something like this.
Okay,
and this is necrosis. This is caseous necrosis, or cheese-like necrosis, just because like macroscopically, it might look like this cheese with all these holes. Okay, so this area is, everything here is dead, okay? So this has these maybe cellular debris, maybe some bacteria in it. I'm going to show you, there's another slide that shows the bacteria really well. Here you can't really see them, but this whole thing is walled off by these immune cells. So these are lymphocytes. Okay, so there are mainly T cells and macrophages. Okay, a lot of macrophages. Here again, because the staining is more specific for the bacteria, you can't really see, but there would be epithelioid cells here, like in the granuloma.
Mm-hmm.
Okay, because this was probably a granuloma first.
Mm-hmm.
Okay, so it began as this granuloma as a type 4 hypersensitivity, and then it became necrotic. And I'm guessing these areas, these were bacteria. And I promise I'm going to show you bacteria in another slide. So you'll be able to see their red little rods. So I think the resolution isn't very good here, but these are probably bacteria.
Okay, and this staining for this, like the bacteria.
Mm-hmm.
Yeah, specific for this bacteria.
Yeah.
Yes. And the site we can see like neutrophil immunocyte, like
no neutrophils, because this is a chronic type of inflammation. This was a type 4 hypersensitivity.
Okay.
Okay, so these would be macrophages and T cells. Okay, maybe some plasma cells, but type 4 hypersensitivity, if you can remember, involve macrophages and T cells, and these T cells would secrete interferon gamma, and that would activate the macrophages, and you would get epithelioid cells that are going to create this granuloma around the bacteria, because the body doesn't know how to kill these bacteria, so it has to wall them off, like put them in a room with no windows and no doors, so they won't be able to get out and influence the body.
Yes.
Okay,
so lighter area is like already necrose. I mean, like already
exactly. This is all necrotic. This is necrosis. You don't see any live cells here. You don't see any nuclear staining. So this is all dead. And these little areas, these little things might be bacteria, but I'm guessing here the resolution isn't good, and they're obstructed by all these tissue debris. But I'm going to show you these bacteria in another slide, and you're going to see what they look like. And here all around you have immune cells. You have chronic immune cells.
But this is like chronic inflammation happens in this region, right?
Yeah. So these are all keeping the necrotic tissue from spreading anywhere else. And
so this site also gonna go like be dead. I mean, like gonna like
maybe not. Maybe not. If they're successful, then they're not. Then this whole area is gonna become calcified, and that would be it. It wouldn't spread, and the inflammation wouldn't continue. Okay. So usually this becomes calcified.
Okay.
And just another thing I have to tell you is, you see this pigment? This is all coal or dust. Okay, just like in the lungs.
Okay. And I just wondering like about the hypersensitivity. We have type 1, and like we can refer like type 1 as the immediate like hypersensitivity, and it means like that region occur, I mean the acute inflammation, can we refer to as like acute inflammation?
No, because it's this immediate reaction. It's IgE mediated, and it doesn't cause inflammation. There are just immune mediators released from mast cells and basophils. But it doesn't. There's no immune infiltration anywhere, so that's why it's not acute inflammation.
But how about, so type 4 sensitivity, like you say, like it can like refer it as the chronic inflammation.
Yeah, it's later on there would be chronic immune infiltrate, especially here because there's a necrosis. So it started out with a hypersensitivity reaction. And this is, it's a lymph node. You have to remember that this is a lymph node, so there would be a lot of immune cells in it normally. But here, they're keeping the necrosis from spreading. That's what they're doing there. It's still a type for hypersensitivity.
Okay. Yeah.
Okay. Sure, anytime. All right, so next up is fatty change in the liver. And so this whole specimen is pathological. Okay, so you're not going to see any normal hepatic tissue here. And I'm going to show you this. And what's really important to understand here is that these are all hepatocytes. These are not adipocytes. These are all liver cells.
Okay.
And what happens here is that the hepatocytes are really sensitive, especially in the center of the lobule. And here their metabolism just got deranged. And this happens, what happens here is this is a part of the reversible cell damage. And in here, they're not, this is an alcoholic, so they're not really feeding themselves right, and there's a lot of enzymatic digestion of the alcohol. And this is where it leads to. So they might ask you about a little bit about this topic if you get this slide. Just know that there's overproduction of triacylglycerol, okay, because there's more like anaerobic processing of carbohydrates, okay, and this will lead to accumulation of fatty acids inside these hepatocytes. But they're still alive, and this is very reversible, okay? So if the person stops drinking and starts eating right, over time, they would become normal again. But what you can see here is the cell membrane, and the nuclei are being pushed to the periphery.
Okay.
Exactly like in fat cells, but these are liver cells. And what you might also be shown is like this area, and this is a triad area. Okay, and I'm gonna try to find a central vein to show you. It's really hard because it just looks like another cell, but this is a central vein. You can see because of the blood. Okay, so if they do show you a central vein, it's gonna have blood in it probably, just to make it easier, because this is really, it would be really hard for you as a student to identify. So you see here in this portal triad, you can actually see the blood inside. Okay, and you can see some blood in the sinusoids.
Yeah, and even like there is like the position of the lipid on the central vein. Yeah. Okay. But not on the triad, I can see like.
No, the lipids are all intracellular in the hepatocytes. So it's hard to find the central vein because because all the lipids were washed out during embedding, so it just looks like another cell.
Okay.
So I don't think they're gonna expect you as a student to know where, unless it has blood in it, you can't know that it's a central vein.
Okay.
Right?
Yeah.
All right. So next up, this is the same thing. This is again fatty change in the liver, but this is stained with red O, and that is supposed to stain lipids red. But this slide this is a really bad preparation. I don't even think, I haven't heard of anyone who actually got this, because it's really bad preparation. This was a frozen section, so it was taken maybe during surgery. Okay, and when you do a frozen section, besides the fact that it's really fast and it doesn't take days to embed it in paraffin, it actually keeps lipids inside the cells.
Okay.
So I'm gonna zoom in, and what you're gonna see is that it looks pretty much like the other slide, and that's why I'm saying that it's a bad preparation, because what it was supposed to do was keep lipids in here, and they would have stayed brown. but you see that it's empty just because it wasn't prepared correctly. Okay.
So lipids should be like stained as brown.
Yeah, exactly. If it was a good preparation, and if you get this, that's what you're going to say. You're going to say that in this slide, you can see it because the lipids were washed out, but if they weren't, then they would have looked brown.
Okay.
So that's all.
Okay.
Okay, so next up, this is called sterulosis in the gallbladder mucosa. And you have these two specimens here, and they're both the same. And so you can see the mucosa here.
Okay.
Okay, and you can see the mucosa, the submucosa. You're gonna be able to see the muscular layer, and this is just fat. Okay, from around it. But what they're gonna zoom in on is something like this. You can see this club-shaped thing. This is the normal epithelium of the gallbladder mucosa. And there's this area that you see that it's a bit darker. This is because there's this pigment in there. It's called gall pigment.
Okay.
And what's pathological here is all of this area, all the lamina propria is occupied by these really big fluffy cells. So these are foam cells. They're macrophages that ingested a lot of cholesterol.
Okay, so this, like, we can see the macrophage here.
Yeah, so this is one, and this is one, and this is one. You can't really see their outlines very well. They're very big. This is the same thing that happens in atherosclerosis in vessel walls. So foam cells. So all of these are macrophages. Okay.
And like macrophage embedded like on the cholesterol. This like the whitish things is cholesterol? No?
Yeah, it's the cytoplasm and it's full of cholesterol. Yeah, and what they do is they take it up, they ingest it, and then they're kind of stuck with it.
Okay. Okay. So what we have to know in this slide is like, okay, like we in the lamina propria, like we can see like the strange material. Yeah.
Yeah.
And could you explain again like the what we have to say like in this slides?
So you have to say that the epithelium is intact and it's columnar and it's showing gall pigment. And in the lamina propria, you see that that it's filled. First of all, it's distended, so the villi are club shaped. And you can see that it's full of foam cells, which are macrophages that have ingested cholesterol.
Okay. Thank you. Got it. Forgot cell is the macrophage. Okay.
All right. So next up, this is a brown atrophy of the heart. And what happens here is maybe there was a chronic ischemia and the heart muscle needed extra energy. And what it does is it begins to break down its own organelles to do it. And for example, like the mitochondria.
Okay.
And then if you look at this, these cells are shrunken. So this doesn't even look like cardiac muscle anymore. So they're very shrunken. And you can see all this brown pigment here. And this pigment is lipofuscin. Lipofuscin is a pigment, like the aging pigment. It shows cellular suffering. And what it is this end product when there's these cells are oxidizing unsaturated fatty acids. And these fatty acids are found in the cell membrane, in other membranes like the mitochondrial membrane, membranes of lysosomes. Okay, so they're breaking them down because they need energy. And they can't get enough oxygen and nutrients. All right, so macroscopically, if you look at this heart, it's gonna look more brown.
Okay. Okay, this like whitish like lining is
these are artifacts, so you wouldn't see these spaces between the cells, because when you embed a tissue in formalin, it shrinks.
Okay.
And you have these spaces between the cells, but there wouldn't be normally.
Okay. I mean, okay, so you said about the fatty acid, like will deposit? No?
They will break it down.
Yeah.
Okay? They will metabolize it, and you can't fully metabolize fatty acids without oxygen.
So
So what's left over from it is this pigment.
Okay, because we cannot like degrade like fatty acid properly like without oxygen. That's why like atrophy undergo.
No, the atrophy itself begins because there's ischemia. There's chronic ischemia.
Yes.
Okay, and because of that, the cells are forced to begin digesting themselves. Okay, and the pigment is because they cannot break down this pigment unless they have more oxygen and nutrients from the outside. And they're not getting that, so it's just there. It's just it's left inside the cell.
Okay. Yeah.
All right, next up. This is a simple endometrial hyperplasia. What you have here is a section of the uterine wall. This area is the endometrium, and this area is the myometrium, and I'll just show you for a second just so you can see. I don't think they're gonna really focus on this. So this is all muscle and in different orientations. Okay. So this is the myometrium, and what they're interested in is this part. And this is an endometrium, and this endometrium is hyperplastic. And here they can ask you about the difference between hyperplasia and hypertrophy. And what the difference is that in hyperplasia, you have an increase in the number of cells. And in hypertrophy, you have an increase in their volume, but the number of cells stays the same. So this is hyperplasia. And you have a hyperplasia of the of the epithelium of the glands. So these are all glands. And you also have hyperplasia of the stroma. All right, so I'm gonna zoom in on a gland. Okay, and the glands of the endometrium range from being cuboidal. So epithelium is cuboidal, like in the very beginning of the cycle when there's no hormone stimulation. And it becomes more columnar the more it's stimulated by estrogen. So here there's a lot of, this happens because of estrogen stimulation.
Okay.
So you can see that they're very, very columnar. And you can see that there's pseudostratification. So it kind of looks like it's stratified, but it's not. It's a single layer. But there's no room for the nuclei. So they're kind of all over this place. Okay?
This is nuclei, right? Like this, yeah, the dark.
Yeah, the dark portions, yeah, are nuclei. The cytoplasm is seen here. Okay.
And this is columnar.
Yeah.
Because of the stimulation of the estrogen.
Yeah. And if you can see the nuclei, you see that they're very big. And the nuclei, the chromatin is very loose. Okay, so it's slightly staining. It's overall dark staining, but I mean, you see this?
Yeah.
So very loose chromatin. These cells are active. They're dividing. Okay, they're producing proteins. so this is the glandular epithelium, and this is the stroma, and you can see that all these cells are just have these big nuclei, and this is chromatin, and these nucleoli. So these are very active cells. Okay, so they're all dividing. They're all producing proteins. Okay, and you can see it all over with the glands here.
When we have the hyperplasia, like the cell will be activated and and they produce the protein. Which protein?
Whatever proteins this tissue produces. So you don't necessarily need to know it.
You mean like hormone?
No, these are not producing hormones. These glands would produce these secretions, these mucin-like secretions, for example. You don't need to know that.
Okay.
You don't need to get into that.
Okay, thank you.
All right. So the next slide is also of a uterus, but this is the complete opposite. So this is atrophy. And here there's a lack of hormonal stimulation. So maybe this is a postmenopausal woman. But there's also a region of hyperplasia here. And this is a leiomyoma. It's in the myometrium. And you're also going to have a separate slide about it, but this is a smooth muscle tumor, benign tumor. So I'm going to start with this part, which is the atrophy. What you need to know is that this is the uterine cavity. Okay, and we're going to zoom in. And you can see that this would be like maybe 2 millimeters. Okay, and if you remember the slide from before, it was huge. Okay, and when you look at these glands, you see that the lumen is very small, and the epithelium is very cuboidal. So this is all very shrunken. Okay, single layer cuboidal epithelium, and when you look at the stroma, you see that it's very dark. So these cells are not active. Okay, they're not dividing. Just look at their nuclei; they're very, very small. Okay, so that's atrophy. Okay, and again, this is because of lack of hormonal stimulation, so no estrogen.
Okay, the opposite of the previous slide.
Exactly. And this area, so this was probably left over from when this woman was younger. Because leiomyomas are also influenced by estrogen, but you'll still have this little tumor here. And
okay, go on.
Okay, and this is a smooth muscle tumor. I'm gonna zoom in, and you're gonna see these. So these are all smooth muscle cells, and they're very, very elongated. Okay, and so these are all these tumor cells. Okay, and it's completely benign. I mean, there's less than 0.5% malignant transformation or something like that. So the only thing it does is it pushes on the tissue around it. I'm going to show you here. So it causes what's called compressional atrophy. It presses on the tissue, and it just atrophies. Like if you think of a person that broke their arm and they put a cast on and they take it off after like 6 weeks, and the arm looks a little thinner than the other arm.
Yeah, exactly.
It's the same thing.
Okay, so the tissue will push, like the normal tissue, I mean the surrounding tissue will push the leiomyoma, and
the other way around, the leiomyoma will push on the surrounding tissue. And just there would be this, so this would have been normal muscle,
Okay.
But it's atrophied. It's atrophied because it got pushed, and there's not enough blood supply because it got pushed. Okay, doesn't have room to grow.
Wait, I think I misunderstand because okay, so this leiomyoma push the normal tissue and normal tissue will shrink. I mean like undergo the atrophy.
Yeah. Yeah, you got it. Okay, compressional atrophy, that's the term.
Hello?
Hey, you still with me?
Yeah. And can I ask you?
Yeah, sure.
Yeah, the leiomyoma like will push the normal tissue. So that's why like atrophy will be undergo.
Yeah. Yeah,
So
it's just
like
little atrophy in the surrounding tissue.
not that because of the lack of the estrogen.
No,
Right.
not in the myometrium. So this part of the slide, this is because there's no estrogen.
Uh-huh.
Okay.
This is the endometrium.
Yeah. This is the
Which
endometrium. So that's because of the lack of estrogen.
uh-huh.
But in the myometrium, this is hyperplasia of smooth muscle cells. And here you'd see some atrophy of the normal myometrium. That's because it's pressing on it.
Okay, understand. Yeah, got it.
All right, next up. So this will show nodular hyperplasia of the prostate gland. Or benign prostate hyperplasia, that's the term, the medical term. So what you see are two specimens. This upper one, that's normal prostate gland used as a control. And this is the hyperplastic prostate gland. And I'm going to start with the normal one just because I need to show you something. The only thing they can ask you about the normal one is okay, so these are glands. Okay, and these are completely normal prostatic glands. And what you can see is all these areas. So these are these little eosinophilic dots. These are called prostatic concretions, like concrete. And these are just secretions that were not secreted outside, and they just accumulate. Okay, so prostatic concretions, they're completely normal. It's not considered pathological. And the older a man gets, the more of these he has. Okay, so you can see a lot of them. And they're all around the glands here.
Okay, so they cannot like release the hormone enough, so that's why like they deposit here around the tissue, around the gland.
Yeah, not the hormone though, the just the secretions.
Okay, secretion. Okay.
So that's the only thing they might show you in the normal specimen.
Okay. And this is not pathology.
No, this is completely normal. It doesn't interfere with
it's not a pathologic lesion or something.
No. All right. So next up, this is the hyperplastic part, and you have these nodules. You have an adenomatous nodule, which is the gland epithelium that's hyperplastic. And then you have the stromal nodules, which is the stroma around it that's hyperplastic. All right.
Okay. Yeah.
So I'm zooming in here, and you can see that this gland is huge. It's huge compared to the normal ones. Okay, and I'm gonna zoom in, and you can see that again. There's maybe some pseudostratification here, and the epithelium is very, very tall, tall columnar. Okay, just these big glands. So this is just hyperplasia of this glandular epithelium.
Okay.
Okay, and then in the stromal section, in the stromal nodule, you can see a lot of stromal cells. Okay, so this is all stromal cells, and they're kind of elongated, and you can see these big nuclei, and between them there's some loose connective tissue. Okay, so this is all considered smooth connective tissue, and you can see a lot of cells. And what's important to know about benign prostate hyperplasia is that it's found around the urethra. So it's centrally located, and it can obstruct urine flow. And cancer, okay, prostate carcinoma, would be found at the periphery, will begin at the periphery of the prostate.
Okay. Not periphery, the begin.
Yeah. Yeah. Carcinoma would begin in the periphery, and this benign hyperplasia, it would begin in the center.
Okay.
And this is very common in men. So let's just say that over the age of 70, maybe 80% of men will have this, even more.
Okay. So why it happens? It undergo the hyperplasia in the prostate.
This is because of hormone stimulation, so testosterone.
Okay.
And yeah, so I mean, you don't really need it for this semester, but next semester you're gonna have a topic about this. And what you do is you actually you can block like give a medication that will decrease the hormone stimulation and decrease it in size. So this is because there's a lot of it's dihydrotestosterone stimulation here on this tissue. Okay. Right. Next up, this is bile stasis in the liver. And this happens because there is an extrahepatic bile duct obstruction. So there's a lot of backup of bile into the liver. And when I zoom in here, okay, so you can see that this is liver. Okay, you can see that these are hepatocytes. And you can also see all this pigment, and all this pigment is bile, and you can find it intracellularly, like here, and you can also find it in the spaces of the say, in bile canaliculi, and the larger bile ducts. And I just want to show you in the larger ones, in the larger bile ductules, you can see these. And these are called bile plugs. Okay, so that's just a lot of bile that plugs the ductule or the duct. Okay, and the way the person is gonna look when you see him is gonna be jaundiced.
Jaundiced. Okay. The like brown this specimen which you have shown me like before. Like
the brown atrophy, you mean?
Yeah, I mean.
No, that's not. It's not the same.
This is like bile stasis, which you shown like this. Yeah.
Yeah, that's all bile. So the pigment here is bile.
Okay, that's it. Like, could you say again like what we have to say like in this slides?
Yeah. So you say that this is a specimen of liver, and you can see it because you can see the histology, okay, with the portal triads and maybe some central veins. But you can see orange pigment that's located both intracellularly and in the spaces of the say and bile canaliculi, and that's bile. Okay, and that it happens because of extrahepatic bile duct obstruction, and you have these areas inside bile ducts that are called bile plugs.
Okay,
and all of these, that's some inflammatory infiltrate.
Okay, thank you.
Sure. All right, so next, this is a specimen of kidney. It's stained with Congo red. And it's a specimen with amyloidosis. Now, if they ask, you cannot give a diagnosis of amyloidosis just based on this slide. It's just not possible, because with amyloidosis, you have to stain it Congo red, and you have to put it under polarized light. Okay, and you're gonna get an apple green positive birefringence, and without that, you cannot say that this is amyloidosis.
Okay, so we cannot say amyloidosis on this slide.
Yeah, so you can say that this is a slide of amyloidosis in the kidney, but yeah, you would have to see it under polarized light, blah blah blah. Okay.
Okay.
So what you can see here, is that this is the cortex, and this is the medulla. And we're going to go to the cortex because the amyloid substance accumulates in the glomeruli and in the wall of afferent arterioles. So this is a glomerulus. And what you can see, this darker red staining here, and this would all be green if we put it under polarized light. And it's found in the mesenterium of the glomerulus. Okay, and what I'm gonna try to find you an arterial that's stained red. So you see all these areas in the wall that are more red staining. So that's also amyloid. It's mainly in the afferent arterioles.
Okay. So when we have the amyloidosis, like this area can be seen more darker or more lighter.
It's more red staining, but if you put it properly under polarized light, it would be very green.
Green. Okay.
Right. So here they might ask you about amyloidosis.
Okay.
Right.
Yeah. The lesion can be seen in the glomeruli only.
In the mesenterium of the glomeruli and in the wall of the afferent arteriole.
Could you show me again, like afferent arteriole, the lesion of the afferent arteriole?
Yeah, you can't really see it very well here. You're gonna need like the polarized light. Come on. So you can see these areas that are more darkly staining here.
Okay. Got it. Yeah. Thank you.
All right. So next up, this is seborrheic keratosis of the skin. And this is a lesion that's found in older individuals. And it may be a little itchy, okay? And but it's completely benign. I'm gonna go here. I'm just gonna show you that this is normal epidermis. Okay, and this is normal dermis. And I'm gonna go over to the lesion. And what's important to see here is, first of all, there's this structure, and this is called a horn cyst, and it's full of keratin, and the pigmentation is melanin. So this is just a structure. There are no cells in here, and this is keratin and melanin. And with the growth itself, so this is all
yeah.
Okay, so this is all epithelium, and it's very hyperplastic. And then there's these areas. These are like finger-like projections with connective tissue, and they kind of feed this epithelium. And the origin of this epithelium is from the basal layer of the epidermis. So you can see these cells kind of have these larger nuclei, and they're producing a lot of melanin.
Okay.
And that's pretty much all. I mean, this is again completely benign. So this would not turn malignant. So again, what you have to say at this is an exophytic growth. It grows outside, toward the outside. It has this epithelial component and this connective tissue component that kind of looks like dermis, and the horn cysts that are filled with keratin and melanin. Okay, and there's melanin hyperpigmentation in the epithelium. That's why it's darker.
Okay.
And just gonna show you here. These are macrophages that ingest tissue macrophages that ingested melanin. That's why they're very, very, very dark, and they're called melanophore cells.
Okay.
So every time there's an area with increased melanin and it's released, you're gonna see these macrophages that ingest it.
Okay, and this is connective tissue, like surrounded by the macrophage, this brighter area. This is connective tissue.
This is like dermal projections into this.
Okay.
That this would have small blood vessels. Okay. That'll bring nutrients to the epithelium. Okay.
Okay.
So next. This is hemosiderosis, and hemosiderosis means that there's an increase in hemosiderin. That's a pigment that's composed of a lot of ferritin, and ferritin is an iron storage complex. There's a whole lot of there's iron overload here. Maybe there's chronic hemolytic anemia, or maybe multiple transfusions, or hemochromatosis, the genetic cause. So this is a specimen of liver. This one is in H&E, and the next one would be in Prussian blue. And I'm going to zoom in, and what you can see is this is liver tissue. I'm going to zoom in and show you in a bit. Do you see all this connective tissue? So there's actually liver fibrosis here. So this is all fibrous connective tissue. And if it continues, there might be cirrhosis. And this is more for next semester. So this is just fibrosis. With cirrhosis, you also need regeneration. All right, zooming in here. And you can see that it's liver tissue. You see this arrangement in rows. And you see all this pigment. And all this pigment is inside the cells. It's intracellular pigment. And this is all hemosiderin. Okay, so pigment is hemosiderin. The bluish dots here, these are the cell nuclei.
Okay.
So this is just all full of hemosiderin. And I'm gonna go to this, and this is all fibrous connective tissue. There may be some cells that remain here, so these are cells that stay here, and you might also be able to see these macrophages that also have hemosiderin in them. And I can't really point to one. I don't know which one is a macrophage or not. Can't really see them, but they're gonna look something like this.
Yeah.
You remember the Kupffer cells? They're the hepatic macrophages. Yeah. So they just take up extra pigment.
Okay.
Okay, so this is all connective tissue. There would be fibroblasts here. Okay, maybe more immune cells. I think this would be something like a macrophage. Sorry, what do you want to ask?
Yeah, like this connective tissue is like made by, I mean, like the inflammation or something? No?
There's not a lot of inflammation here. It's just fibroblasts.
Okay, so it's like normal.
It's not normal. It's not normal.
Wait, okay.
It's not normal. This is all pathological. So a liver should not look like this. But just the accumulation of all this hemosiderin here, it creates this stromal reaction.
Like kind of like fibrinoid, the necrosis?
No, it's not necrosis. It's fibrosis.
Fibrosis.
Okay. So fibrosis is a process where fibroblasts release a lot of collagen.
It's kind of scar formation? No?
It's maybe a little similar, yeah.
Okay.
All right.
Good.
So in this slide, this is stained with Prussian blue, and that's a staining method that will stain iron. So when I zoom in here, you're not going to see really the cell membranes. Okay, pretty much all you see is these areas, and this is all the pigment. Okay, this is all iron. It stains iron, and you use it mainly for the liver and also bone marrow.
Okay.
Okay, so Prussian blue stains iron.
Okay. Iron means including hemosiderin?
Yeah.
Okay.
Yeah, are you okay to continue?
Yeah.
It's okay if you need a break, if you want to continue some other time. So
but if I stop here, like, you know, like the class will be take, I mean, like 4 times, I guess. Like, yeah.
Yeah, we just did an hour. So if you want to continue more, we can do that. Or if you want to stop and continue later or tomorrow, that's okay with me too.
I wanna finish let's say 30 slides today.
Okay, sure. So we'll continue. All right, so next slide. This is an arterial thrombus. So this is the artery. And you can see that the wall is thickened. And inside, this is the thrombus. Okay. And a thrombus will only be formed in a live organism. Because you need all this activation of the coagulation cascade. So if it's after death, it's clots. It's called clots. So not thrombi. And why is it laminated? Because it has these layers. So you have this dark layer. These are red blood cells. And you have this lighter layer. Okay, and that's platelets and fibrin. Okay. And what you can also see is this, and this is recanalization. So the blood is trying to get through. Okay, so these are areas of recanalization.
Okay.
All right.
So,
yeah.
Guess we have to mention, okay, where is thrombi, where is like fibrinoid region, and then recolonization.
Yeah.
That's it.
Okay. Yeah, and they might mention the lines of Zahn. I'm going to show you picture here. And lines of Zahn are these lines of red blood cells and fibrin and platelets and red blood cells again. This form with these really straight lines would happen in areas with a faster flow. Somewhere with a faster flow. So here it's just laminated. These aren't really lines of Zahn. They might just mention it because they mentioned it in class with I mean some of the teachers did.
We cannot see like the lines of Zahn here, right?
No, it's just laminated because the flow wasn't fast enough to create them.
Okay. Got it. Thank you.
All right. So next, this is an end-stage lesion in Berger's disease. Berger's disease is a small to medium-sized vessel vasculitis, and it's pretty much only in smokers.
Okay.
So these are specimens of skin, and you can see the epidermis and the dermis and hypodermis. I'm gonna go here. This is a nice lesion. So this is a small artery, a small elastic artery, and this is the wall. And the wall is very thick for an artery. And this would be the lumen. But what you can see here is that it's closed off. This is a fibrous plug. And all these little areas are areas of recanalization. Okay. And this has been going on for a while because you can see the endothelium here. So it's recanalized and it's covered in endothelium. Okay, but this is not enough, to fully restore the blood flow. So usually it's in the limbs, so in the hands and in the feet. And that's not enough like for a normal blood flow. It's just an attempt. Now, what's important here is you see this wavy line. This is the internal elastic membrane of the artery. And the reason it looks like this is because there's shrinking of the collagen fibers. And this is pathognomonic for Berger's disease. Pathognomonic means a feature that is a pathological feature that is just very unique to a certain pathology. Okay, and this is called a Spanish collar. If you can imagine paintings of all Spanish people, they have this collar that is that looks like this.
Yeah.
All right, so this is just collagen fibers that are that shrunk a little bit.
Why so like how to say like up and down like this?
Because of the shrinking. I mean, I'm gonna show you an internal. Okay, I'm gonna show you like a normal photo of it. Not shopping, even though I'd love to be doing that. Okay, so you see, it is kind of wavy, but it's even more so here. It's very darkly stained. Okay.
So this is because of shrinking.
Yeah. Because if you think about it, this fibrous plug here, it's sticking to the endothelium and it's pulling it in. Okay, and that's part of what causes this.
Okay.
Right? Right. Next up. So this is necrosis of the small bowel because of incarceration. What that means is there was probably a hernia, and a segment of the bowel got pushed through the hernia wall, and there was ischemia because the blood vessels were compromised. So in this specimen, what you can see here is here you have a normal bowel tissue, okay, with all the villi. But then it stops abruptly, and this whole segment is necrotic.
Okay.
Now I'm gonna zoom in on this, and you can already see that it's very eosinophilic. So this means that there's not a lot of nuclear staining, and this is pretty much dead. What you can see here, all of these are neutrophils mainly, because there's inflammation. And if you notice, so you see that here it's a little more pinkish, and this is more red. That's because these are red blood cells, and this is the necrotic tissue here. So this is a red infarct. Or hemorrhagic necrosis, and that's because in areas where there's a dual blood supply, you're going to get this red infarct. And if you think about the bowel, technically there's only one artery that's going in, but this artery will create these arcuate arteries. So there's gonna be some anastomosis there, and this is why you get a red infarct in the bowel. So it's not like a classic two circulation, like for example in the lungs where there's a pulmonary and a bronchial circulation.
Yeah.
But because there's a lot of anastomosis, you're gonna get the red infarct.
Okay.
Okay, so this is all just necrotic tissue with a lot of inflammation here. These are all neutrophils. This is an acute inflammation, and a lot of blood here in the tissue. Right?
Okay. Yeah. Okay.
So next up, this is a nutmeg liver. And what a nutmeg liver means is there's this chronic liver congestion. And you can see it when there is a right-sided heart failure, for example. I'm going to move in. I'm going to show you what I mean. Okay. So you can see that this is liver. Okay. So you can see the hepatocytes. And there are two areas. There's this area where you can actually see pretty normal hepatocytes. And there's this area. This is the central lobule. And you can see fatty transformation here. And if you remember, like the hepatic lobule has 3 zones. Okay, and there's one zone that's like getting this fresh blood. Okay, and that would be this. And then you have the middle zone that is just it's getting all the nutrients last. It's getting like all the leftovers. So this area is suffering from this congestion. And how do you know that it's congested? Just look at these sinusoids. They're full of blood.
Okay.
Okay, so blood is just standing here. Okay, because the heart is not pumping well enough. Okay, so you see all this blood congested here. So what's also important to see is you see all this brown pigment, and this is all partially digested blood. Okay, or and that's this brownish color. So it can be intracellular. Like here, it's inside the cells. Some of it can be extracellular. So what you have to note here is all these congested sinusoids, It's the fatty transformation here. Okay, it's the partially digested blood.
Right. Like, okay, we have like hepatocyte and like okay, around the central vein, like they cannot really get the oxygen like from the triad.
Yeah.
So like this like adipocyte, we can see like the aggregation of adipocyte here, and this is like more central or more peripheral of the hepatocyte.
But these aren't adipocytes. You said adipocytes. Don't say that in the exam. These are all hepatocytes.
Yeah, hepatocyte. Yeah. Sorry. Yeah, hepatocyte.
If you think that you're gonna mix them up, say liver cells. It's better to say hepatocyte once and then say liver cells. And if the examiner like says, yes, but what are they called? Then you say hepatocytes, and you can even explain that you sometimes you get your words mixed up, and you say that you don't want to say adipocytes and not mean it. Okay, just explain that you're saying liver cells just because you don't want to mix it up when you're speaking, and they should totally understand.
Okay. Okay. So this like fatty like transformation, and this happens like around triad or around central portion of the hepatocyte. I mean, like I don't really.
It happens. Okay, I'm gonna show you. Let's see, liver histology. And I just want to. So this is like the normal. I think that's what I'm.
Yeah.
Yeah, because I wanna show you the one with the zones. Zones.
Yeah.
All right. Okay, so these are the zones, and zone 1 is getting this really nice oxygenated blood because it's sitting right on the triad. So the triad has like an artery from the hepatic artery, and the hepatic artery is the one that is oxygenated. And the third zone here is always suffering from low oxygen tension because so the central vein contains mostly non-oxygenated blood. Okay, so that's why this area that's close to the central vein will have fatty transformation. And the area next to the triads will be more normal looking.
And you showed us this, like the red things is like the blood stasis, like blood here.
So this and is that will sorry?
Occur in like zone 1 or 2 or 3?
No, in all the liver. The stasis is just in the entire liver.
Okay, got it.
Okay.
Yes.
So next up, so this is a hemorrhagic infarct in the lung, and we talked about the fact that the lung has 2 separate blood circulations, the bronchial and the pulmonary. And if we go to the periphery here, you'll be able to see that it's actually a lung. So you can see these alveolar walls. And you can see that these are huge alveoli. And this person must have had emphysema, and in emphysema there's destruction of alveolar walls. So maybe this used to be like 4 or 5 alveoli, and the walls got destroyed, and now it's just this one huge one. Okay, and then I'm going to take you to this area, and this is the area with the thrombus. Now, with lungs, this must have been a thromboembolism. So there might have been a thrombosis in a deep leg veins. And this thrombus got swept away in the blood with the blood flow. and ended up in the lung. So this is completely obstructing an artery here. So this is a fibrous thrombus, and here you can see recanalization. So this must have been long-standing, okay?
So, okay, this whole circle, I mean, like this whole thing is the artery.
Yeah, so this is an artery, and this is a smaller one. And these are just thrombi that it got cut here. Okay.
Inside the recanalization area, like we can see the dark red thing. This is like thrombi.
This is blood.
Okay, blood. Okay, they try to go through.
Yeah, this is blood. All right, and the area with the necrosis is here. Okay, so here you can see that you can't even see the normal lung architecture. So this is all just one big mass, and what you can see here is the dead tissue, the necrotic tissue, and red blood cells, because this is a hemorrhagic necrosis.
Okay, so red blood cell infiltrate the parenchyma of the lung also. Yeah,
because there's one circulation that's blocked off. And then you have one that's still working, and the blood just spills.
Okay.
It's not infiltrating, it spills into the tissue.
Can we say like hemorrhagic infarct? Like, can we say as red infarction?
Yeah,
like,
exactly. It is.
Okay.
Yeah, that's what it is. And if they ask you where you can see a white infarct?
In the heart and in the kidney. Yeah.
Exactly, in the spleen.
Yeah. Spleen, okay. And like the previous slides, I don't know which slide, but you showed us like the red infarct in the small bowel, right?
In the intestine, yeah, this one, it's 18.
Like the intestine have the two how to say the double like the blood providing
dual blood supply. So technically with the intestine, there's only one artery going in. So if you remember, like the superior and inferior mesenteric arteries, but there's a lot of anastomosis between blood vessels, and there's these arcuate arteries, like in the small bowel. If you picture the mesentery, and you can see these nice arcuate arteries, and that's why it's sort of a dual blood supply. That's why it'll give you a red infarct.
Okay, because of like a lot of anastomosis of the artery. Okay, thank you. Got it.
Sure. Okay, and last thing I need to show about this slide is you see all this pigment. So this is partially digested blood, like all the brownish stuff here. And if you see areas that are kind of darker, that might also be a coal, because it's still a lung, so there might be some coal here. But most of the brownish pigment, if it's more brown, then it's partially digested blood. Okay. All right.
So this like darker area is like the normal.
The darker areas like that's coal. And if you remember from your autopsy, coal is like dust.
Okay.
If you remember from autopsy, the lungs are kind of dark. Like there's a lot of black on them. That's that. Especially in Debrecen. In Debrecen, there's a lot of dust. So people who lived in Debrecen all their lives will have these really blackened lungs, even if they don't smoke, which most of them do.
This is physiological condition, right?
Yeah. So if you live where there's no dust, then your lungs might not have all this coal in them. But but the lungs are prepared for dust. So they have these macrophages, these dust cells that will the phagocytose it. Okay, so it doesn't hurt the normal tissue.
Like, which is the most influenced area, like by the red infarction? Like the lighter area or the dark area?
This area is all infarcted. So if I'm going to zoom out, this whole thing is infarcted. Okay, this entire thing.
Yes. Then the dark area is like more severe.
No, it's all. I'm gonna go in here, and the darker areas just have more red blood cells in them. But this is all. This is all dead tissue. Okay, this is all infarcted.
Okay.
It just has less red blood cells in it.
Okay.
It just depends on where the blood vessels are.
Okay.
So maybe here there's a larger vessel, and that's why it's bleeding more.
Okay.
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 All right. So next up is pulmonary edema. And this is a lung, and pulmonary edema happens a lot in left-sided heart failure. And even if I zoom in a little bit, you can see that it's a lung. You can see all these alveolar walls. And what you can see is instead of the alveolar spaces being clear, you can see the substance, the slightly staining substance. And this is transudate. And transudate is a lot like plasma. So not a lot of protein, but more liquids. Okay, and this is just filling the alveolar spaces. Okay, so this area is not capable of performing gas exchange.
Like, yeah. In the physiological situation, we cannot really see the color inside the alveolar, but like in this slide, we can see like lighter, very light.
Yeah. So if you were in an autopsy room, what you would see is if you cut into the lung and press it a little bit with a knife, you're gonna see this froth coming out. So this kind of foam. Okay, yeah. So that's what you're gonna see. You're gonna see that the lungs are full of fluids.
Yes, actually, in the autopsy class, we have like we can see the fluid like with pus, I think, pus.
So no, so this will not have pus. So you might have seen pneumonia.
Okay. Okay. So edema is like the liquid which is induced by like transudate, right? Like so that's why like excluding the protein.
Yeah. So no. So almost no proteins here. In an exudate, you're gonna see proteins. Okay. And exudate would be more like pus.
Okay.
And the transudate is very clear, very like plasma. Like if you take blood, like you take someone's blood and you put it on the side, and you can see that the top portion is very this yellowish, almost no substance. That's what it is.
Okay. Okay. And the difference from the normal tissue is what in this slide is like this lighter area like is filled with the fluid. That's it?
Yeah, because this would be clear. This would normally have air.
Okay.
And the other thing you need to see here is this. This is a blood vessel, and it's congested with blood because it's not flowing, because the heart is not pumping properly. Then you're gonna see all this blood here, and the pigment is partially digested blood. Because it's been here for a while.
This is cause of the edema, or this is cause of the heart failure?
What happens is there's the heart failure, and blood becomes congested in the lungs. And so you see it congested in the blood vessels, and this creates this pressure. Okay, I don't know if you remember all the laws of, but it creates a hydrostatic pressure, and it moves fluids from the blood vessels and if you remember, there are blood vessels. There's little capillaries all in the alveolar septa, and it pushes this plasma inside the spaces.
I got it. Okay, edema is induced by the left heart failure. That's why, right?
Yeah. Okay. So next up, this is acute suppurative appendicitis. And what suppurative means is with pus. Now you have these two specimens. This is the same appendix. It's just a different orientation. Okay, so here you can see. So this is the lumen here, and this is the lumen here. And what you can see is this: there's a mucosa, and there's a submucosa, and there's a small muscular layer. But the entire thing is just invaded by acute inflammatory infiltrate. Okay, so it's full of neutrophils. Just a lot of neutrophils in the entire thing. And you see that see this, it's like it's completely destroyed. So there would be like nice villi here normally, and now you see that they're all sloughed off. So these are immune cells, red blood cells, pieces like tissue debris, and bacteria. And the lumen here, which should be clear normally, is just full of it. So this is all pus. If you remember, there was a minima about it. The pus contains bacteria and immune cells and cell debris. So this is that. This is pus. And what's important here also is see this area, and this is MALT, mucosa associated lymphoid tissue, and the appendix is full of it. So it's found in the submucosa, and the appendix is full of it. These are all lymphoid follicles. Now these are full of pus too. Okay, so it's not normal. Okay, because there's an infection here. But what happens, especially in kids, the MALT in their appendices are like very active, and there might be lymphoid hyperplasia. So these follicles would be very big and will obstruct the lumen. And you know, the appendix is a blind pouch. So if you obstruct the lumen, there's stagnation of all this fecal matter inside, and there will be bacterial overgrowth, and that's what's going to lead to this inflammation. So in kids, it's because of mostly because of lymphoid hyperplasia in the MALT area. And in adults, it's because of fecal matter that obstructs the lumen.
Okay. Could you show me again the separative area?
Yeah, so this entire thing, okay? This is all pus. This is all suppuration.
Okay, because we can say, okay, like a large amount of the neutrophil, like lymphocyte.
It's mostly neutrophils. This is a very acute inflammation. So this would be maybe a few days old, like 1 or 2 days old. Okay, so neutrophils. Okay, so this is all the suppuration, and this is in the lumen, but you can also see infiltration into the tissue, into the mucosa. Okay, so all of these little guys, they are all neutrophils.
Okay.
Right?
Yeah.
So next up, this is purulent meningitis. So again, it means pus. And what you have here is you see brain. This is brain tissue. And you're going to see, I'm going to zoom in a little bit, but here you're going to see some of the pia matter. This large thing, that's an artifact, so it wouldn't normally be here. And over here, I'll show you remnants of arachnoid membrane, okay, arachnoid layer. And the pus itself is flowing in the subarachnoid space. So between the arachnoid membrane and the pia layer, you're gonna have pus. And because it's pus that's free flowing in a cavity, it's called an empyema.
Yeah.
Right, so I'm gonna start showing you now. I'm gonna zoom in here. I'm going to show you that it's actually brain tissue. that these are neurons. And you can see, like, this is a nice pyramidal cells. These are just all neurons, okay? So you can see all these cells, all these are cell bodies of the neurons, okay? So that's brain tissue. And I'm gonna go over here to the edge because I want to show you like the remnants of the pia. And the pia is a very, very thin layer that adheres to the brain. So that would be it, okay? So there are just remnants of it. It's pretty destroyed either from the inflammation or because of the slide preparation. But that's where it would be. And this is pus.
Okay.
Okay, and we're gonna talk about it in like a second because I want to go to where I can maybe see some remnants of the arachnoid layer. So it's just remnants. You're not gonna see like a nice layer because it's pretty much destroyed here. So I'm gonna go over to this area, and this is again, this is pus. So it has bacteria and it has immune cells and it has tissue debris. And this is all found where the cerebrospinal fluid would normally be.
Okay.
I can also see some blood cells here. So there's some hemorrhage.
Okay.
Okay, so this is all pus. And this is usually because of bacterial infection.
Yeah.
Okay. You cannot know what caused this just from looking at the slide. So you're gonna need to do a lumbar puncture and culture it. Okay, maybe send it like to do some immunological methods, but you can't know what caused this. You can say that it might have been bacterial infection just because it's purulent.
Okay.
All right.
Yeah.
So next up. So this is a systemic abscess in the myocardium because of candida infection, so yeast infection.
Okay.
So this is all myocardium, and the staining here is pash. Okay, because the fungal wall has a lot of carbohydrates in it, so that they used pash to see them better. So I'm just gonna take you over here, like to the edge of it. I just want to show you this. You see all this brown pigment? This is lipofuscin. So and there may be some atrophy here with the muscle. I just want to show you because fungal abscesses would not happen in a person with like a good functioning immune system. Okay, so this person was sick and maybe he had AIDS, maybe I underwent chemotherapy. Okay, but this wasn't a healthy person. That's why he had fungal sepsis. So all of this is lipofuscin, and that's because there's this heart muscle was suffering. Okay, and now I'm going to show you this area. Okay, and this whole thing is an abscess. Okay, no, it's an acute abscess. You know, there are acute and chronic abscesses, and the difference is in the wall. So the chronic abscess will have this double wall, so this less cellular inner wall, and then the outer wall would be composed mainly of immune cells. So this is an acute abscess. So you're going to have immune cells on the outside, and then this cellular debris and the candida here in the middle. And this is a sort of liquefaction going here. This is all liquid, okay? And so I'm going to go from the outside in. Okay, and you can see all of these nuclei belong to immune cells, and these are mainly sorry, polymorphonuclear cells, so mostly neutrophils. Okay, so when you go more inside, you can see that you don't see the nuclear staining anymore. So this is all necrotic inside, okay? And here you can see these structures. Now that's the fun guy, okay? So Candida is a budding yeast. And so this is a bud. And these elongated structures are called hyphae. Okay, so that's how you know that it's a yeast. Okay, and what you should be able to see is that these cells, like the nuclear staining, it looks good. But the more we reach the inside of the abscess, you start to lose nuclear staining. Okay, until here, it's all dead.
Okay. So this happens in dark area, and like, could you, zoom out?
Yeah, so
like you can see like lighter area.
This whole thing is a huge abscess. So yeah, so so you have the layer of immune cells here on the outside, and you have all this necrosis inside.
And this is acute abscess.
Yeah.
Because we don't have like outer area like which composed of the like connective tissue.
Yeah, exactly. You don't have the double wall.
And the brighter area, like the outside of this dark area, like we have like brighter area, is that like normal tissue?
Here, yeah, it's just muscle, just cardiac muscle.
Okay, thank you.
Next. All right, so next, this is a chronic non-specific salpingitis. Okay, and so this is a specimen of a fallopian tube. And this would be the mucosa, and then the submucosa, and there's some, you see some muscular area here, but this tissue is pretty much destroyed. So I zoom in, you're going to see a lot of inflammatory infiltrate, and this is chronic inflammatory infiltrate. So macrophages, T lymphocytes, plasma cells. Okay, and you see that it's all in this, it's kind of broken up. There are debris here inside the wall. Okay, and it's all infiltrated. And over here, you see that if you imagine like a normal fallopian tube, I mean, it doesn't have this huge lumen, okay? There are all these villi that are protruding, but here you have almost absolutely no lumen at all, because this is all inflammatory infiltrate and cellular debris. This would also have bacteria in it. Okay, so this is there's no normal tissue. There's like a small area here that you might be able to find, just to show you the villi that would have been here. Where is it? Here we go. So that's what it would look like, you know, normally if there wasn't an infection. So you see the epithelium and you see the lamina propria here, okay? So that's what it would be like. Now, okay, and all of this is just tissue debris and inflammatory cells and some bleeding. And what causes this is actually, the most common organisms are chlamydia and gonorrhea. Okay, and that could lead to a chronic infection. I mean, this may have been going on for years even.
Okay, so comparing to the normal, the villi, like, okay, for pathological situation, we don't really have like the lining tissue. I mean, like the epithelial tissue. Like, could you explain again?
All you see here is tissue debris, so you don't see anything else. It's just tissue debris and chronic inflammatory infiltrate. Okay, so you don't have any of the normal tissue. You just have remnants. Okay, so if you look here, this was an epithelium, like once upon a time, but right now it's dead.
Okay.
It's just disconnected.
Okay.
All right.
Okay. Thank you. Yeah.
All right. Next up. So this is where I told you I was going to show you bacteria. So I'll go through it in a minute. So this is a lung, and I know that in like the slide list, it's supposed to be tuberculous lymphadenitis, but it's not. Because this is a lung, and I'm going to prove it to you. I'm going to show you this portion. You can see that these are alveolar septa.
Okay.
Okay. So it's not, because it's a pathological slide, it's not really supposed to show them like very well, but you can see like that these were alveoli, and you can see this, and this is the coal, the dust that's usually found in a lung. And what they're going to show you in the exam is this. This is a granuloma. Okay, and what's important is that this slide is stained with Ziehl-Neelsen again. Okay, because we want to see Mycobacterium tuberculosis. So you're not gonna see all the, you're not gonna see like a nice staining for the granuloma with all the epithelioid cells and everything. But I'm gonna show you a granuloma in the next slide.
Okay.
So, so this is a granuloma, and basically it holds bacteria inside, and on the outside you see all these elongated epithelioid cells that are the macrophages. Here in the periphery, all these blue dots. So these are probably all some T lymphocytes and maybe some macrophages on the outside. Okay. And this is the area of the granuloma, and all this blue, that's calcification. And you see all these little things? That's the bacteria. But just imagine that that you're seeing them through cells. That's why you can't really see them. You only see, sort of see them.
Okay.
Okay, so this is the granuloma that they're probably going to show you, but just in case, because I know that some of the people were shown another area in class, so I'm going to show you this. Okay, and this is free bacteria. All these little red rods are the mycobacteria. So this is just like when I studied pathology, they didn't show us this part of the slide. Okay, but like what's his name? Chaba Molnar. He showed people in his class this area. But this is just free bacteria. This is not the granuloma. The granuloma is the purple thing.
Okay, so this is like for free bacteria, free tuberculosis.
Yeah, exactly.
Okay. Yeah.
All right.
My teacher is Chaba Molnar, actually.
Yeah, so he might have shown you this.
Okay, might. Maybe.
Yeah, but the actual thing you're supposed to talk about is this.
Okay.
All right. So next, this would be a foreign body granuloma, and this is a piece of skin, and it's very distorted. What happened here is there was probably a cut, and it was sutured. And the foreign body is the suture material. So you don't see really nice layering of skin here, but this would have been the hypodermis, and that pinkish part would have been the dermis, and all this darker staining purple part would have been the epidermis. And you see all this black pigment here. This is not melanin. This is dirt, probably. Because if you can imagine, if you hurt yourself and you get a cut, there's a lot of dirt pushed in there.
Yes, yes.
So this is dirt, okay? And now I'm gonna show you a granuloma, and there are a few here. So this is one, and this is a big one. Okay, I'm gonna zoom in. And you see all these elongated cells, and these are all epithelioid cells, which are these activated macrophages. Okay, and this is a sort of type 4 hypersensitivity because well, there's suture material in there, and the body doesn't know how to get rid of it.
Okay.
So it walls it off. Okay, it just walls it off. So what you're supposed to say is about these epithelioid cells, and you say that you see here in the periphery there might be some T lymphocytes, some activated T lymphocytes, and you might be able to see areas like these, and these are the giant cells, the Langerhans giant cells, which are fused macrophages. Okay, so you see a lot of inflammatory infiltrate. It's perivascular, okay, because what they're doing is how do they get to the tissue? They're coming here in the blood flow, and then they're leaving the blood vessel.
Okay.
Okay, so epithelioid cells, the activated T lymphocytes, and the epithelioid giant cells, which are things like
elongated nuclei. It's like we can say this is the epithelioid cell, like this, like elongated nuclei.
Yeah. Okay. So this is an epithelioid cell. Yeah. All right.
Yes. Can I see the giant cell here?
Yeah. So it's something like this. If they actually show you a giant cell, it's probably going to be like a close-up of it. And you can just see that it has eosinophilic cytoplasm and a lot of nuclei together.
Okay, thank you.
Sure. Okay, so next up, these are rheumatoid nodules and rheumatoid arthritis, and this is subcutaneous tissue, and you see a lot of nodules here. Okay, and this is very common in rheumatoid arthritis. And I'm gonna zoom inside, and what it is, each nodule has an outer layer of epithelioid cells, and inside it's fibrinoid necrosis, like in vessel walls. Okay, so this is all necrotic. That's why it's so darkly eosinophilic. Okay, and all of these are epithelioid cells. Okay, and you can see a lot of collagen in the surrounding tissue. And there's some collagen here too. Okay. And here, there might also be these giant cells. Okay, they may look something like this. But I haven't like seen a really nice one that I can show people. But there might be some giant cells in the periphery. Okay, what's important is fibrinoid necrosis and the epithelioid cells here. So that's what's important.
So, like out of the epithelioid cell, we might see the giant cell.
Yeah, so there might be a few giant cells somewhere here. It's just kind of hard to see because it's all densely packed.
I thought I misunderstood that, like I can see like the giant cells surrounded by the epithelioid and like lymphocytes, but it's not.
No.
Okay.
There aren't a lot of giant cells, so it's mostly the epithelioid cells and maybe some lymphocytes here in the periphery. So these may be some activated T lymphocytes. Okay,
Yeah.
and you might be able to see a giant cell here and there, but they're not very prevalent.
Okay.
Right. Okay, so next up, this is organized pneumonia. And what happened here is you had pneumonia, and in pneumonia you have these exudates that fill the alveolar cavities.
Yeah.
And in this case, it didn't have anywhere to go, so it just stayed there, and that's how it became organized. So I'm going to show you first of all this area, which shows alveoli. Okay, so normal alveoli, but you can see that it's very congested with blood. Okay, that's because of the pressure from the pneumonia. And I'm going to show you this area. And this is the area of organized pneumonia. So what does it mean? That all these exudates actually became like fibrous granulomatous tissue, granulation tissue, sorry. So all of these, this area is just fibrous granulation tissue. Okay, and this is no longer an area that is capable of gas exchange.
Okay.
And what I also want to show you, I'm going to show you like this area. And if you remember, so this is all, I mean, it doesn't even really look like lung anymore. Okay, but if you can see these, so this would be the alveolar septa. But you see that the cells, if you remember, like normally the cells would be like squamous cells, so very flat, because you want to do a proper gas exchange, and like the flatter they are, the better the gas exchange. But here they kind of look cuboidal. And that's because they are. It's called bronchial metaplasia. And just because of all of these processes going on with all the fluids and the granulation tissue and just inflammatory cells flowing in there, they become cuboidal, and that'll also interfere with the gas exchange if there was air in here, which there mostly isn't. They're mostly this fibrous granulation tissue. And the other, sorry?
Okay, like it's so basic question, but pneumonia happens in the alveolar space or parenchyma of the lung.
It depends on which type of pneumonia, and it's not really. You're gonna have more topics about it, I think, in next semester.
Okay, but like I was wondering because like okay, the pneumonia affect the gas exchange, like yes.
If there's exudate in the alveolar space, then there's no air getting there, so you're not gonna have any gas exchange there because it's just all full of fluid.
Because of exudate, yeah. Okay.
Yeah, so a pneumonia can be in the alveolar spaces or in the septa. And if it's in the spaces, there's no gas, and if it's in the septa, then the septa is thickened, and it also interferes with the gas exchange.
Okay.
That's just basically, because at this point you don't really need to know that, but it's good if you do. So just remember the fibrous granulation tissue. Okay, and the bronchial metaplasia, and then you can see other things that you normally see in the lung, like dust cells. So this is a macrophage, and it has dust in it. So if they show you it's still a lung, there's still the normal things that a lung has.
Okay. So what's the red one? The red things. If you zoom out, like we can see like the red things.
Like here?
Yeah.
That's blood. That's a big blood vessel.
Okay.
Right? Okay.
Okay, what's this dark area?
That's again dust. This, I think it's a lymph node.
Okay.
I don't think I know it. It's a lymph node. So if you see this is a lymphoid follicle and this is a lymphoid follicle. This one. So it's a lymph node.
Okay.
Right?
So the last,
Sorry?
yeah, okay, I got it.
Got it. Okay. So I'm thinking maybe we'll stop now because we're like on 2 hours and when do you want to continue? Do you want to do like the same hour tomorrow?
Yes.
So okay, so 10 o'clock tomorrow and we'll finish everything because the next slide is similar to the one after it. So like the vasculitis. So I prefer to do it all.
Okay. So I will review like this today's material, and can I ask you like if I have question about today's material like tomorrow?
Yeah, of course, you can ask me anything.
Thank you very much. Thank you. And like when like can I like pay for you?
So what you do is when we finish everything, how many hours? It'll probably be 4 hours, and I'll give you my sister's phone number. And
Okay.
and you can give her the money.
Okay. And 1 hour is like
5,000 forints. Okay, so today it was 10,000, and you'll just pay her. You know when we're finished. She has an exam on Friday, so maybe after that you can talk to her.
Okay. Thank you.
You're welcome. So okay, so tomorrow at 10, we're gonna do the same thing.
Yes, thank you very much. I appreciate.
Sure, anytime. Okay, so bye. We'll talk tomorrow.
Yeah, bye.